Thank you. I'll start recording this session. Yeah, I'll just share my screen with you. So you're host today. Are you teaching today then? I'm not teaching then. Yeah. Okay, so this is opened up. Share screen. Any questions in between, please let me know. I'm happy to answer them. So yeah, we were here somewhere. So we've done this and we were talking about urban versus rural. We've done that. Don't worry about the sessions. If you want a repeat of them also, I'm happy to do that like next weekend maybe, and we can just go through whatever we went through earlier. That's not a problem. Okay, so we were talking about the sizes of health and social care sector and within the chosen country of your choice. So provision compared to population. Now, we were talking about the GDP, that it's a big concern that the GDP is not that high compared to how much is required for the spending on healthcare. So there are some countries, some economically developing countries that have a very low GDP. However, they have to spend a lot on health. So if you're spending on health, that's okay, that's good. But if you're spending
Hello.
on, yeah, can you hear me?
Sorry, he's asking me to record to cloud.
Yeah.
I should record to cloud?
Yes, please.
I already denied it.
Okay. Oh, no. You've denied it.
Yeah.
I don't know. It's recording at my end.
Okay.
That's okay. The recordings is it's there at my end, so that will be saved. Yeah, hopefully.
Okay.
Anyways, thank you. So, for instance, if in 2017, if we consider the UK expenditure on health, so it spent around 3,000 per person on healthcare, and that is around the average number of OECD countries per person. So that's okay. But then if we see, the UK was spending the second lowest. So that's not really good. If your expenditure is high on health, that is good. If your expenditure is high on education, that is good. But if it's the second lowest, that's not really good. And then its expenditure, healthcare expenditure fell from 9.8% in 2013 to 9.6%. That's also very low. So the UK's publicly funded NHS, it's based on the taxation system. So whatever taxation is being used within the country, that is then used for the NHS. The private sector is different, it's separate. So it's one of the highest shares of publicly funded healthcare in the OECD. And then in 2017, the UK spent an equivalent of £560 per person on health-related long-term care, which was less than most other Northern or Western European countries, but a similar amount to France and Canada. So as I said, the higher the, because we're making a lot of money within the country, but the expenditure should be high as well. When it comes to health and health-related expenditures or education. So then we go on to explain how health and social care provision is funded within your chosen country. So there's state funding. So the NHS is funded mainly by general taxation, which is supplemented by national insurance contributions. We all know that, NICs. So in England and Wales and Scotland, local authorities, they're responsible for adult social care, and this duty is set in law. Funding comes from central grants, which can be subject to squeezes from central governments and from council tax on property. So all of these taxes that are deducted, they all go into the state fund, and that is how the NHS supports treatment and other whatever is required for every patient. So then, okay, so we see there are several factors that impact a country's expenditure. So let's say you have a high immigration rate. So there are a lot of people coming within the country. That obviously will increase taxes, but only if those people are payable to like they're eligible to pay taxes. So if you're bringing in people who would not be contributing to the country's taxation system or to the NHS, then it becomes a very big burden for any country in this world, any kingdom in this country, in this world, to be able to balance the influx of people. And then if they're not having to pay enough, and they're still getting the quality of life, that whereas there's another person who's working day in and day out and just to make ends meet for themselves, and then they're paying more, then it becomes it's not equality in a way. So yeah. And then there's private health insurance that we've talked about earlier. So private health insurance, it's a type of insurance which covers the cost of private healthcare in the UK. It's similar to other types of insurance. So you pay a monthly or annual premium, and your insurer will pay for some or all of the cost of private medical treatments that you receive. So yeah. So it's and then you have NHS charities. So there are more than 250 charities across the UK. And there are many of them that focus on helping our hospitals, supporting them in order to do more. And then collectively, these charities give about around 1 million every day to the NHS, so that people can stay well for longer and get better faster. So if you're giving in charity, you're actually helping the NHS. So that's something to be proud of. That's something to look forward to next time. So that's why we see so many charities and so many, like so much going on there, and so much volunteer work going on. This is just to support the NHS, because there's so many people who require treatment and they can't afford it. So in recent years, the NHS charities have funded major capital projects, pioneering research and medical equipment in their several hospitals, helping patients access the best possible care when they need it the most. So they also play a key role in mobilizing volunteers in order to support the. Yeah, again, I'll start recording. Okay, it is recording. The process isn't. Okay. I don't know. It's something, the internet's not very helpful today. Anyways, can everyone see the screen? Can everyone see my screen? I'm not sure. Yeah. So there are other NHS charities that support mental trusts, mental health trusts, community health trusts, and ambulance trusts also. So then we have the health and social care spending. Where does the money go? Okay, there is some issues going on with the internet. I'm not sure what it is, but I'm just trying and fixing it up also. I'm sorry for this. It's not, doesn't happen normally. I hope you can see my screen now.
No.
Yeah, can you see my screen?
No, I can't.
That's. Can you see it now?
Yes, I can.
Okay, thank you. So hopefully it will go okay now. Okay, thank you, Esther. Okay, so in 2015 to 16, we see that the public sector, UK public sector, spent around 220 billion on health, social care, and benefits to support people who had disabilities and health conditions. So this is equivalent to 11.5% of UK's national income, which is a huge amount, and 28.7% of the total public spending. So this is just one chunk. So it's just supporting people with disabilities and health conditions. Then there are several other conditions that obviously the health expenditure goes there also. So the majority of the 140.6 billion, so that's 63.9%. Where was it spent? It was spent on 49%, 49 billion pounds was spent on benefits and 29.9 billion was spent on social care. So there are new forecasts or predictions from the Office of the Budget Responsibility that was released in January 2017 that indicated that rising demographic and cost pressures could result in 14.7% of national income needing to be spent on health and long-term care by 2066 to 67. So that's a big amount. So obviously, that is why we are all equal. No one earns a lot more than the other because a lot of this goes into charity and the NHS support as well. Then there's this point where we outline how the sector is regulated in your chosen country. So what is regulation in healthcare? So regulation plays a major role. So if you have regulation in your structure, in your program, it helps to give you a way of how you would have to work. It lists down what is supposed to happen, what should be happening and what should not happen within a healthcare sector, for instance. So there's an inspection report also that is generated. So there are various regulatory bodies that protect the public from number of health risks, and they provide programs for public health and welfare. And these regulatory agencies, they protect and regulate public health at every level. So there are several organizations, as I said, that work towards regulation. So there's Care Quality Commission that was established in 2009. You listen to a lot about the CQC in your lectures. So CQC is an independent health and social care regulator for England that's responsible for registration, regulation, inspection, and rating of all providers. So it gives you regulation, and it could turn your regulation down also. So your registration down also, depending upon if there is any major quality concern that they have. So what is the main objective is to protect and promote health and safety and welfare of the people who are using health and social care services. Its remit includes both the NHS and local authorities, as well as independent providers of health and social care. So yeah, it's just not concerned with the NHS. It works with local authorities such as the council as well, and other independent providers such as the taxation departments, for instance. So it's concerned with a lot of more. It's just not the NHS that it works with. And then how your sector is regulated in your chosen country, we talk about this. So the CQC, it's required to perform its function for general purpose of encouraging whenever there's improvement of health and social care services, there's provision of health and social care services in a way which focuses on the needs and expectations of people who use those services, and the efficient and effective use of resources in the provision of health and social care services. So there are other regulatory bodies also. So for instance, there are 12 health and social care regulators, including the Health and Care Professionals Councils, which is known as the HCPC, and its role is to protect the public. And then you have the General Chiropractic Council, the GCC, which regulates chiropractors. And then you have the Dental Council, the General Dental Council, GDC, which regulates dentists, dental therapists, dental technicians, nurses, clinical dental technicians, and orthodontic therapists. You have the GMC itself that regulates doctors. So all of these are responsible for regulation. They have their own ways of regulation. So they might not work like the CQC, but they work alongside. Then you have the General Optic Council, which regulates dispensing opticians and optometrics. You have the General Osteopathic Council, which regulates osteopaths, the Nursing and Midwifery Council, which regulates midwives, nurses, specialist community public health nurses. You have the Health and Care Professionals Council, HCPC again, which has loads of work. So it has to do with paramedics, with physiotherapists, with physician associates, clinical scientists. There's several other, for instance, you have the practitioner psychologists. So all of these come under the regulation of HCPC. And then you have the General Pharmaceutical Council. As the name suggests, it's for pharmacists all over the country. Pharmaceutical Safety of Northern Ireland, which deals with pharmacists and pharmacy premises in the Northern Ireland. Northern Ireland Social Care Council, which regulates the social care workforce only in Northern Ireland. You have the Social Care Wales. The social care workforce is regulated by them only in Wales. And then you have the Scottish Social Services Council, which works in Scotland only and is responsible for registering people who work in social services. So there's several ways in which there's regulation and monitoring going on within the UK, for instance. We'll talk about this in detail. So if I just make this bigger. So there's monitoring in which it's defined. So for instance, if we take the GMC's monitoring, for instance, I'm just giving an example. So what does it do? It's an independent regulator, and it sets the standards that are required for doctors who practice in the UK, and it deregulates them also. So if there's regulation concerns, if there's a clinician who's not performing well, their regulation might go down. They might not be regulated then, and they might have to reappear for the exam and do all the process again. You may have CQC that I've been talking about. So it's an independent regulator for quality in health and social care in England. And it includes private providers as well. And it registers and inspects hospitals, care homes, GP surgeries, dental practices, and other healthcare services. And if the services are not met, they're not according to the fundamental standards of quality and safety, the CQC has powers to issue warnings. Otherwise, they just slash them from the list. So there are several organizations that I've just mentioned in a nutshell. So you can have a look at all of them and what their services are within the NHS. If we have time, we'll go through it, but I don't think because we have another session also. So then we analyze how health and social care spending within your chosen country works. So public spending on adult social care. Now, these are very helpful. These graphs, this is a pie chart. These are very helpful. You can use pie charts for your chosen country as well. They're there. There's published data on them, so you can always use them. You'll have to just document from where you've taken them. So that's a reference that you would give. So for instance, in England, there's a major chunk that's spent on disability. If you see, disability benefits are around 7.6 billion. Then the local authority adult social care is 16.8 billion, which is followed by incapacity benefits, which is 12.8 billion, and benefits for carers is 2.8 billion, which is a huge public spending chunk. So yeah. And then we analyze the health and social care spending for your chosen country again. So what is the budget? So a Department of Health and Social Care's budget. So if we see from this year on to this year, okay, so for instance, if we see, there's a spike over here. So for instance, it was going from 2008 to 9, it was going from 118 billion pounds, and then it rises to around 150 billion, which is acceptable. But after that, if we see to 2020 to 21, Yeah, so if we see the NHS, for instance, has spent around 63.4 billion more. So 148.7 billion was spent on a regular basis, but then there was 63.4 billion more expenditure because of COVID funding. And then as COVID was controlled, that expenditure went low to around 22.4 billion. So the normal expenditure was 159 billion, which is expected. Obviously, a rise is expected, but then this went higher because of COVID-19. And then we analyze the current funding. So funding for health services in England comes from the Department of Health and Social Care's budget, and planned spending for Department of Health and Social Care in England was 212.1 billion into 2020 to 21, and up from 150.4 billion in 2019 to 20. This would include more than 60 billion of extra funding for the Department of Health and Social Care, responsible for the COVID-19 pandemic. This included procuring personal protective equipment for staff. You had staff. Okay, so we didn't have only these things that were used, these perishable amount of things that were used. We had other concerns also because staff wasn't there enough. We didn't have enough people working for us because people were dying as well. People were unwell, so we had to have replacements. We had to have their wages also. And there were testing and tracing programs going on. There were waits for reducing waits for care because there were more care concerns at that time. So there was a lot going on during COVID, because of which the expenditure went really high. Now, as I mentioned yesterday when I was talking a bit briefly about how would you have to do your assignments, in that you had an analysis also. So please make sure that you're analyzing.
How many, the contract they give you?
You can't hear me.
Is it 48 hours? Oh, yeah.
Sorry? I don't know. Anyways, yeah. So in the analysis, please.
Sorry, I'm sorry. I'm at work. I didn't know that I didn't mute.
Okay, that's okay. I thought you were.
So I can hear you clearly.
Yeah, that's okay. I was just concerned if you can't hear me. Yeah, that's okay. So in the analysis, please make sure you're analyzing. When you're writing, you're analyzing as well in your assignments. So most of the department's core budget, excluding COVID-19 spending, was revenue funding for spending on day-to-day items such as staff salaries, medicines. The remaining was for capital spending on buildings and equipment. So you needed equipment. You needed a building also, for instance, for testing and other services. And this was for the improvement of the NHS England and for health services. And the rest was allocated to other national bodies for spending on other health-related functions, such as public health, training and development of the NHS staff, and regulating the quality of care. What are the recent changes to funding? So during the period of austerity that followed 2008, there was an economic crash. The Department of Health and Social Care budget continued to grow, but at a very slow pace than compared to previous years. So the budgets rose by 1.4% each year on average, adjusting for inflation in the 10 years between 2009 to 10 to 18 to 19, compared to 3.7% rise since the NHS was established. So this 3.7 was high compared to just this budget that was rising every year. So that was also a backset for the economics within the country. So NHS 5-year funding deal, there's that deal that exists within the NHS. So in July 2018, the Prime Minister announced a new 5-year funding deal that would see NHS funding rise by 33.9 billion in cash terms by 2023 to 24 compared to 2018 to 19. and a rate of increase that is closer to, but still lower than the long-term average. So we still needed more. So this long-term funding deal only applies to services that are within the England's NHS England's mandates and excludes important areas which are like such as capital investment, public health, and the education and training of NHS staff. So then there were manifesto commitments and COVID-19. There have been several increases to public spending since the 5-year NHS funding deal was announced in September 2019 spending round. The government announced increases to budget for capital investment, public health grant, and the education and training budgets for the NHS work service. So all of this is being shared with you because this is how you will have to work on your assignment when you're working on your country of choice. So in March 2020, there was a spring budget where the government provided further boosts to capital spending and 5.4 billion of revenue funding was there until the end of the Parliament. This was to support its manifesto commitments on more clinical staff, more GP surgery appointments, greater community-based care for people, and learning disabilities who have learning disabilities or autism, and free hospital car parking for some groups. So then there's certain other changes that occurred. I'm not going through the detail because this is mostly COVID-19 related. Your country of choice would also have COVID-19 related aspects if they have been impacted by the COVID-19. I'm not going to go into details because I have another session to deal with. This is just a summary of what happened during COVID-19. So a substantial share of extra COVID-19 funding, which we saw, was not maintained in the budgets allocated to the department after the pandemic ended. So that budgeting went somewhere else. So those concerns are also there. So I'm stopping share over here. And then I'll start sharing for the next LO, which is LO2, which is not very extensive compared to this one. I'll start sharing my screen. So our second learning objective is to understand health and social care provision for different ages and stages of life. So this is, I hope you can see my screens. So the different provisions for different ages and stages of life. So the human lifespan, throughout the human lifespan. So we have even before life, we have the infant who's in the mother's womb. Life starts from there actually. So the lifespan varies both in length and in terms of experiences from one individual to another. Some aspects of development are fixed and unaltered, whilst others depend on our surroundings and how we interact with those around us. Some events we expect, but others, obviously, we didn't expect COVID-19 to happen. That happened, so we don't expect everything to happen as it is. A variety of factors can affect individuals and their development, both positively and negatively. So we have different provisions for different ages and stages of life. So working in the health and social care sectors, you will care for people of different ages and personalities. Some will be vulnerable, others will not be. So there'll be different levels of disability or impairment also. Others might not have it. They might be physical impairments, they might be mental impairments, or both together. And then these are the points at which health and social care provision may be required during a lifetime. So there are key stages. For World Health Organization defines health as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. So it's not just the absence of disease that means health. It's also the physical, mental, and social well-being. We've talked about well-being, what is meant by well-being in our yesterday's session. So it focuses not only on reducing mortality, we don't only focus on reducing deaths and disease, but also on the impact of health determinants. So there's several health determinants that we'll talk about in due course. So we have the economic, the environmental, and social conditions on health and well-being at various stages in life. So if we start with the ages and stages of life, it starts from infancy, goes on to early childhood, to adolescence, early adulthood, and later adulthood. So every stage has its own requirements. So in infancy, for instance, a midwife is a healthcare professional who is trained to support women during pregnancy. We know that childbirth and early postnatal stage. This midwife will be an important aspect during this phase. So midwives are also responsible for delivering the information listed below. So that's examination and monitoring of the fetus. There's undertaking screening tests and keeping records. Post-prenatal care at home in hospitals and surgeries, providing practical and psychological support for women, their families during childbirth, supporting families during pregnancy to prepare for parenthood, providing support in case of bereavement, and training and mentoring student midwives and others. So this is promoting the care of 0 to 2 years old. And it's so that's the stage where you have the midwives working most heavily. Then you have the early childhood. We've talked about it. So you have health visitors that come to children 5 years of age and their families. So they work alongside the school nurses, doctors, social care workers, and other health professionals. They work from homes, clinics, or surgeries. You have health visitors, you have support, family support workers, you have family assessments also going on. So family support workers would provide support for complex needs with children and babies. So that's, for instance, you have the children's educational attendance. They work for that also. The family support worker would also work with parents or carers at home or in groups. And in the family assessment, they provide an opportunity to get to know the whole family better. So they work around with the family and they help in coping at nurseries or schools also. So that's the whole family assessment. And then you have the adolescent stage where there's support through adolescence. You have, obviously, with adolescents coming in, you have major other changes in life also going on. So there's a major transition that happens between 10 to 14 years of age, including moving from primary to secondary school. This could have a mental impact, physical impact as well. The substance misuse that has been heavily targeted over here within this country. So you have community mental health teams working, you have social workers work around here, local authorities that invest in substance related service provision across different levels of from school targeted provisions with groups who are vulnerable to drug use and specialist services treating young people's substance misuse. Again, with the adolescents, you have mental health and well-being. So they work with with young people, and 11 to 16-year-olds have most of them have, as data have shown, have a diagnosable mental health disorder. Then they work for homelessness also, because of when you're going through this stage, you could experience this homelessness, whereas when you're a child, the impact might not be so hard compared to when you're reaching your adulthood. Then there's childhood obesity and physical activity, which has been which the community workers have been working with in supporting children with their weight, and their pledges are to provide them with the latest tools so that they can help reduce children, young people and families with their weight. So with childhood obesity and physical inactivity, you have diabetes, you have hypertension, you have all other concerns as well. And then we talk about early or mid-adulthood. So they're different, this is a different stage where there are different changes again occurring. It encompasses a wide range of lifestyle choices and responsibilities. The people launch directly into adulthood at a legal age of 18, while others take much prolonged course. It's mentally being an adult also, not only physically. So there's change, which is always stressful. It could be good or bad. So in this period, there's a lot of support out there also. So in this stage, you have the stressors of this time period can worsen pre-existing conditions as well. So there could be difficulty coping with emotions. You have alcohol and drug abuse, academic or employment difficulties, family discord or parental issues, marital issues, financial stresses, spiritual issues also. There's treatment out there. There's a broad range of specialists that are working including the psychiatrists, psychologists, and licensed therapists also, who are there to support people during their early adulthood. So in late adulthood, we consider it at the time when we reach our mid-60s until death. And because we are living longer, late adulthood is getting longer with time. A 10-year-old child today has a 50% chance of living to the age of 104 years. But with this living, there's a lot of other disabilities also occurring. You have certain support workers here. So there's home help, there's handy person services, foot care, transport, dementia support, exercise classes, and social activities. NHS also provides support such as social care workers, community nurses, GPs, dentists, hearing and optical care homes, and carers where it is required. Then we go on to describe the health and social care services that are required and provided at different points during a lifetime. So there are many services that are there. So you have maternity services that are there to support women during their pregnancy journey to ensure that their health needs are met. They have pregnancy tests, they have routine checks to delivery services, there's childcare support. So you have support, family support workers, you have practical home help, you have access to children's care support services that provide education or health. There are other health authorities also working with them. And then you have CAMS, that stands for Child and Adolescent Mental Health Services. It is a free service that is run by the local NHS, made up of medical and mental health professionals. You have home care or domiciliary care support, and with the support with cost of medication also. For instance, if you're dealing with long-term medical conditions. And it depends on the person's abilities and the level of care and support that they need or they receive. There are SEN children and young people with special need, education needs support. So these are, there are support workers there. They're in schools, they're in universities, etc. So not in universities, obviously, that's young children. So it's in schools and colleges, basically. And in nurseries. So they support with people with disabilities. So people, I mean young children and young people, basically. And then there's end of life care, which refers to a person when they and generally at the end of their lives, they're dying and they need care in 4 areas. There's physical comfort, mental and emotional needs, spiritual issues, and practical tasks. You have services including the GP for this. You have preventive health care, which deals with prevention of illness. That's to decrease the burden of disease and associated risk factors. You have hospital, social care, and mental health services. So these are all basically the services that are provided at different points in time. Then there's arrangements for long-term care provision. So what is long-term care? So obviously, as we said, that the aging population, it's getting, people are getting older, and there are many more people that are added to that pool. So it becomes a necessity to have a separate budget for them. So long-term care is also known as social care. It may be required when people become ill or suffer a disability, and which means that they are unable to care for themselves, with the possibility that the disability will continue over long term. So there's long-term care provision for individuals with long-term health conditions or disabilities. So these are there to meet the needs and to compensate for functional disabilities of people, whatever age they may be at. This is for those who can no longer function independently. So there's care in community. So this is a strategic vision described in a healthier future. It has objectives that are set out by the department's public service agreement. The key aim is to support an increasing number of people to live independent lives, preferably in their own homes. To do this, the DiHSC needs to develop effective alternative to hospital care, which is designed to reduce inappropriate admissions and unnecessary lengths of stay. And there's also needs to be there's also a need to be a focus on rehabilitation together with assessment of long-term care needs to avoid unnecessary reliance on residential and nursing home care. So what is this care? So there's domiciliary care. It has a range of facilities. So you have personal and continence care. You have managing medication. You have helping to mobilize in and around the home, household tasks that are supported with, and meal preparation, clinical care, including catheters and stoma management and peg feeding. There's several others also. Institutional care. So we talked about domiciliary care. It's institutional care is most common form of long-term care. So elderly people are who are able to interact together. They live in the same institution, while they also have 24-hour care to daily necessities by professionals that provide patients with a sense of security. So it's a residential care for a large group of people or children. So it's characterized by a one-size-fits-all approach, according to which the same service is provided to all children, irrespective of their age, gender, and whatever is required. So institutional care could be there for elderly as well as for children. So it is usually provided by a large organization that is mostly comprised of nurses, nurse practitioners, doctors, therapists, nutritionists, and many more. So if it's like people who are really challenged or who are going towards the end of life, they could then suffice through this. And then within the UK, we have how services are accessed. So we have direct contacts made by ourselves. This is through dentists and opticians. We have through contacts through the GP or referral. We have private health insurance providers. We have social services. We have support through educational establishments also. What are the barriers to accessing services? So there are several barriers. We could talk about regional, social, economic, and policy barriers. Talk a bit about regional barriers. So some people live near health and social care services. Some people live away. So it's hard for them to travel to distances. So for instance, if I'm living in another town setup and there's a checkup for my child and I have to travel to Manchester, it becomes really hard for me. So this is a mobility problem, and it becomes hard for some people to travel on their own. Then there's social barriers. So you have psychological barriers. So this affects the people, the way an individual thinks about the service. So they may have fear from the dentist, they fear the GP also, they may have fears from the psychiatrist also, from the psychologist. So that is a psychological barrier. Financial barriers may be there. So you might find that your system is costly. So it might be transportation that you're accessing. There are people who won't have to pay for their medical prescriptions and they are on long-term medication. That also could create a financial barrier on them. Economics would be a resource barrier. So some people, sometimes the health and social care and early years services, they might not have the services available because of staff shortages or lack of money for the service. So there's no services available there for them. There may be high demand for vaccination against a disease. There's not enough vaccine available, for instance. So that is a resource barrier. For instance, we have it with flu barriers. And then coming towards the policy barriers. So there are several policy barriers. So policymakers should explicitly recognize the need for competition in some areas of care and collaboration with others, and should develop competition rules accordingly. So if these need to be integrated, there may need to be integrated system that have to be established more widely. So what are the ways that these barriers can be addressed? So regional barriers, you could give transport, you could have house visits, pop-up clinics. Social barriers could be overcome by introducing a buddy system where patients can access services with a trusted person, explain steps of procedures. Resources could be distributed more widely. Vaccinations on needs basis could be there to the most vulnerable first. And policies, you can adapt to policies, or policies can be adapted to reflect current needs and requirements and to adopt a person-centered approach. So that's about it. We talked about the points on which health and social care provision may be required during a lifetime. Health and social care services required and provided at different points during lifetime. Arrangements for long-term care provision, how services are accessed, within your chosen country, barriers to access to provision, and how these barriers can be overcome. If you have any questions, please feel free to email us. And that's about it. These are some of the resources that you can use. So there's a bank holiday tomorrow. So these PowerPoint presentations should be uploaded on Tuesday. Yeah. Any questions?
No.
Okay. I had,
That's class, yeah.
yeah, so I'm just stopping share. And